Welcome to the Hospital Medicine Unplugged podcast. We are jumping into a deep dive today on, well, one of the most prevalent and challenging entities we face in acute care, cardiorenal syndrome, or CRS.
It really is. It's the ultimate puzzle on the wards, I think.
Yeah.
We're tackling this highly complex spectrum of disorders, and it's defined by that deeply interconnected bidirectional interplay between the heart and the kidneys.
Right.
The core definition is actually pretty simple. Impairment in one organ precipitates or, exacerbates dysfunction in the other.
Yeah, simple definition.
Yeah.
But the clinical implications are profound, especially in a hospital setting. This reciprocal relationship, it significantly complicates fluid management, it drives diuretic resistance, and maybe most importantly, increases both short-term mortality and that long-term cardiovascular risk in our hospitalized patients. It feels like a real crisis of crosstalk between organs.
That's a good way to put it. Our mission today really is to synthesize the classification system, those 5 types, and crucially, the modern understanding of its pathophysiology, which I have to say has truly shifted in the last decade or so. Then we'll cover the necessary multimodal diagnostic strategies and, critically, the evidence-based management tools. We really need to focus this deep dive squarely on giving you the clinically actionable tools to manage these challenging acute hospital cases.
Okay, let's start with that foundation then. CRS is a pathophysiologic disorder where acute or chronic dysfunction in one organ induces acute or chronic dysfunction in the other. Simple enough. But before we dive into the mechanisms, why is organizing this complexity into a structured classification like the Ronco system so essential for us clinically?
Well, without organization, we just end up treating everything the same, don't we? And that's a mistake here. The Ronco classification system, which was established, years ago now, it remains absolutely essential because it forces us to determine 2 things right off the bat.
Okay, what are those?
First, the acuity, the problem is this acute on chronic or just acute. And second, the primary organ involved. Is it the heart failing first or the kidney? That determination really directs our initial workup and, importantly, our choice of management strategies.
Makes sense. Let's walk through those 5 subtypes then, starting with the one that really dominates our inpatient population, type 1.
Right. Type 1 is the acute cardiorenal syndrome. This happens when there's an abrupt, acute worsening of cardiac function. Think classic examples like acute decompensated heart failure or, severe cardiogenic shock.
Okay.
That acute cardiac event then leads rapidly to acute kidney injury, AKI. This type accounts for, the vast majority of cases we see where aggressive diuresis or maybe hemodynamic support is needed, like right now.
Got it. Then you have the slower burn, type 2, the chronic cardiorenal syndrome.
That's right, the long-term sequela. Here, it's chronic heart dysfunction, often long-standing heart failure, could be reduced or preserved ejection fraction that causes progressive chronic kidney disease, CKD, typically over months or years.
So it's a gradual process.
It is. It's that persistent low-grade inflammation and the chronic neurohormonal activation that just slowly wear down the renal architecture over time.
Okay, shifting the pendulum then over to the renal side. We have the renocardiac syndromes. Type 3 is the acute renocardiac syndrome. So kidney first this time.
Exactly. Acute kidney dysfunction comes first. Maybe severe acute kidney ischemia from hypotension or certain types of rapidly progressive glomerular-free deaths, something sudden hitting the kidney, and that precipitates acute cardiac dysfunction.
And how does that cardiac dysfunction manifest?
Well, it can be quite dramatic. Sometimes it's volume overload leading straight to acute heart failure because the kidneys just shut down urine output. Or less commonly, it might present as severe arrhythmias or even acute myocardial ischemia.
Wow.
Yeah, the toxicity and the inflammatory milieu of acute uremia can directly impair myocardial function. It's quite potent.
Okay, and the chronic version of that is type 4, the chronic renocardiac syndrome.
Right. And this represents the immense burden of CKD driving cardiac pathology. You have the chronic uremic state, plus disturbances in calcium phosphate metabolism, anemia, hypertension, all driven by the failing kidney.
All conspiring against the heart.
Precisely. They contribute significantly to decreased cardiac function over time, and we see classic structural changes here, things like left ventricular hypertrophy, accelerated atherosclerosis, all leading eventually to adverse cardiovascular events. It's a major driver of cardiac mortality in CKD patients.
Okay, that covers the first 4. Finally, type 5, the secondary cardiorenal syndrome. You said this is almost a category of exclusion where the problem starts somewhere else entirely.
Exactly. This is when some profound systemic condition is the primary culprit, and it's simultaneously causing both cardiac and renal dysfunction. Think sepsis, that's the classic example. Or other severe systemic inflammatory states, maybe certain vasculitides or systemic shock syndromes. These conditions drive direct cellular injury, ischemia, inflammation in both organs at the same time. The heart and kidney are innocent bystanders to a systemic catastrophe.
Understood. So this classification, it's clearly clinically useful, especially when you consider the burden. You mentioned it's staggering. If we look at patients admitted for acute decompensated heart failure, the most common type 1 scenario, what percentage are we talking about who already have underlying CKD when they hit the door?
Yeah, the numbers are really quite striking. Studies consistently show that up to 60%.
60, wow.
60% of patients admitted for acute decompensated heart failure already have established CKD. That means, more than half of your acute cardiac failure patients are already starting with this dual organ challenge.
That's huge.
It is. And this combination, whether it's type 1 CRS superimposed on existing type 2 or just the baseline type 2 CKD making things worse, it's an incredibly strong and independent predictor of poor outcomes. It drives high rates of death, frequent rehospitalization. It's precisely why we, as hospitalists, have to approach fluid and hemodynamic management with such precision in these folks.
That clinical burden really forces us to understand the mechanism, doesn't it? For decades, the primary teaching, certainly when I was training, focused on flow dynamics. The heart failed, cardiac output dropped, leading to renal hypoperfusion. Is that still the prevailing wisdom?
No, and this is probably the most critical shift in the pathophysiology paradigm for the hospitalist to grasp. Really important. Traditionally, yes, we taught that low cardiac output led to arterial underfilling, which made the kidney panic and hold on to salt and water.
Right.
And while hypoperfusion is certainly relevant in true cardiogenic shock, absolutely. The modern consensus for most typical acute heart failure exacerbations, the ones we see day in and day out, is that venous congestion is the primary overarching driver of the renal dysfunction.
Okay, let's unpack that because that's a big shift. How does elevated central venous pressure, CVP, cause tangible kidney injury, especially if the patient's systemic blood pressure might actually look okay or even high?
That's the key question. The kidney, remember, is encased in this relatively fixed, tough, fibrous capsule. It doesn't stretch easily. When the central venous pressure, the CVP, rises because of heart failure and systemic congestion building up,
Right, the BACA.
that pressure gets transmitted backwards through the renal vein and directly into the renal parenchyma, into the substance of the kidney itself. This results in two critical things happening inside that tight capsule.
Which are?
One, increased renal interstitial pressure. The pressure in the tissue surrounding the tubules and glomeruli goes up. And two, increased capsular tension. The kidney basically gets squeezed from within by the back pressure.
So it's not primarily a flow problem into the kidney, it's a pressure backup problem within the kidney.
Precisely. That's the core concept. Remember your physiology. Glomerular filtration rate, GFR, depends on the net filtration pressure. That's essentially the difference between the hydrostatic pressure pushing fluid out of the glomerulus and the combination of the oncotic pressure pulling fluid back in and the hydrostatic pressure in Bowman's capsule pushing fluid back in. When the renal vein pressure is high, that downstream pressure, the hydrostatic pressure pushing back into the glomerulus, increases dramatically.
Yeah.
This physically reduces the net filtration pressure across the glomerular membrane. It basically throttles filtration, even if the mean arterial pressure feeding the kidney, the MAP, looks perfectly normal.
That is such a critical takeaway for practice. Decongestion isn't just symptom relief for breathlessness, it's actually kidney protection. Ignoring high venous pressure means you could be actively damaging renal function.
You are. You absolutely are. And this mechanical blockage, this pressure issue, then creates the secondary problem, that vicious cycle of neurohormonal activation we talked about.
All right.
Because even if the total volume in the body is massively high due to congestion, the effective arterial blood volume, the baroreceptors in the carotid sinus and aortic arch are actually sensing, might still be perceived as low. Why? Because the failing heart isn't efficiently pumping that volume forward into the arterial system.
So the body thinks it's dry, even when it's drowning.
Essentially, yes.
Yeah.
And the body's reaction in that situation is completely counterproductive, isn't it?
Catastrophically so, usually.
Catastrophically. This perceived underfilling triggers the immediate aggressive activation of the renin-angiotensin-aldosterone system, RAAS,
Yep.
the sympathetic nervous system, the SNS, and the release of vasopressin, or ADH. These systems are desperately trying to increase volume and vasoconstrict to restore what they think is low systemic pressure.
But in a patient who's already congested?
It's the worst possible response. It leads to intense peripheral and, importantly, renal vasoconstriction, further sodium and of water retention, and worsening volume overload. This just perpetuates the venous congestion and drives the kidney injury even harder. It's a downward spiral.
We can't just blame the plumbing and the hormones, though. What about other factors? Non-hemodynamic factors must play a role too, right? Especially in the chronic types.
Oh, absolutely. Non-hemodynamic factors play a chronic, more insidious role, contributing significantly to both type 2 and type 4 syndromes. We have to recognize the profound roles of inflammation and oxidative stress.
Okay.
Pro-inflammatory cytokines, things like tumor necrosis factor alpha, TNF-alpha, interleukin-1 IL-1, interleukin-6 IL-6. These are released during both chronic heart failure and uremia. They don't just circulate passively.
They're active players.
They act directly as cellular toxins. They promote fibrosis. They drive endothelial dysfunction in both the myocardium and the nephron. This sort of low-grade chronic systemic injury promotes organ deterioration independent of those short-term pressure changes we just discussed. It's part of why CKD progresses in heart failure and vice versa.
This brings us directly to a really key clinical insight, something that confuses many hospitalists, myself included sometimes. The relationship between aggressive diuresis and seeing that creatinine level bump up on the labs. We're being taught, rightly, that aggressive decongestion is paramount.
Yes.
Yet we often see that lab marker rise, and it makes people nervous.
It does. And this is the whole concept of pseudo-AKI versus true AKI. And frankly, it requires some clinical courage to manage appropriately. We very often see a rise in serum creatinine during aggressive diuresis, what some call permissive hypercreatinemia.
Right.
And clinicians often reflexively stop or back off the diuretics, fearing they're causing true tubular injury.
But if the patient is still clinically, demonstrably volume overloaded, JVD edema crackles, stopping diuresis, means leaving them exposed to that damaging venous congestion we just detailed.
Exactly. That creatinine bump in many cases likely reflects simple hemoconcentration. As you successfully remove the excess free water from the plasma,
You concentrate what's left.
you concentrate the non-filtered solutes, like creatinine, its concentration naturally increases, even if the absolute GFR hasn't actually dropped, or potentially has even improved slightly because you've reduced that harmful renal venous congestion.
And the outcome data supports pushing through.
The data are now quite clear on this. Achieving aggressive decongestion, getting that volume off, even if it comes with a temporary, modest rise in creatinine, is linked to better long-term survival and reduced rehospitalization rates. Tolerating that bump if the patient remains congested is often the right move.
So the absolutely critical question then is, how do we know where to draw the line?
Yeah.
If we're accepting some permissive hypercreatinemia, what are the real warning signs that we've actually gone too far, that we are causing true tubular injury, not just hemoconcentration?
That's the crux of it. We absolutely must rely on objective assessments that go beyond just that single daily creatinine number. Context is everything.
Okay.
So if the creatinine rise is accompanied by clear signs of severe volume depletion, things like orthostatic hypotension developing, worsening symptoms of dizziness or presyncope, or critically, if the urine output suddenly drops off dramatically without a corresponding increase in natriuresis.
That's a red flag.
That's a major red flag. We need to pause and reassess then. And perhaps even more importantly, if the creatinine rises significantly, say more than 0.5 milligrams per deciliter above their baseline, and the urine sediment starts showing active signs of tubular injury, like muddy brown casts.
The casts.
That's a very strong warning sign of true acute tubular necrosis, ATM. In that case, you absolutely need to back off the diuretics, maybe even give some fluid back and rethink the strategy. You've likely crossed the line from hemoconcentration to actual injury.
Okay, that distinction is vital. This whole discussion transitions us perfectly into the necessity of using a multimodal diagnostic toolkit. We simply can't manage what we don't measure properly, and clearly, just relying on a single daily creatinine is insufficient when managing the dynamic pressures and fluid shifts in CRS.
Absolutely insufficient. The clinical presentation is, of course, the starting point. Patients presenting with those overlapping features, severe volume overload, maybe reduced urine output, and that hallmark diuretic resistance. But labs and imaging must drive the diagnosis and, just as importantly, the ongoing monitoring.
Okay, starting with the lab assessment, we monitor the routine markers, daily serum creatinine, BUN, electrolytes, and you've emphasized tracking strict urine output. But you also mentioned the urine sodium as key to managing diuresis.
Yes, we absolutely need to quantify natriuresis, the urine sodium excretion, to truly gauge diuretic effectiveness. A patient who's getting, say, 160 milligrams of IV furosemide twice a day, but is only excreting 40 millimoles per liter of sodium in their urine.
We're resistant.
They are functionally diuretic resistant regardless of their total urine volume output. They might be putting out water, but not salt. Beyond those daily markers, looking at prognostic biomarkers like cystatin C or assessing the degree of albuminuria or proteinuria can provide crucial information about underlying chronic renal damage and the baseline filtration status. This helps differentiate acute injury from that chronic background disease.
And critically, before we even fully commit to the CRS pathway and just focus on volume, we have to eliminate other potential causes of kidney injury, right?
That is non-negotiable. A careful urinalysis and a urine sediment examination are absolutely required early on to exclude intrinsic renal disease. We must rule out things like a primary glomerulonephritis or an acute interstitial nephritis, maybe from a drug.
Because those need totally different treatments.
Entirely different treatments, often immunosuppression. You can't just diurese those away. So rule those out first before focusing solely on the hemodynamic and volume management aspects of CRS.
Okay, good point. Moving on to imaging and hemodynamics. Transthoracic echocardiography, TTE, seems foundational. Gives us cardiac function, ventricular size, pulmonary artery pressures. What about the specific utility of the E to E prime ratio for these patients?
The E to E prime ratio. It's critical because it gives us a non-invasive estimate of left-sided filling pressures. It looks at the relationship between the early mitral inflow velocity, the E wave,
Okay.
and the mitral annular tissue Doppler velocity, the E prime wave. A high E to E prime ratio strongly suggests elevated left atrial pressure, signaling diastolic dysfunction and high filling pressures backlogging from the left ventricle.
So it confirms backward failure.
It helps confirm the presence of backward failure, absolutely. It reinforces our need to decongest aggressively, not just for systemic volume, but specifically to prevent pulmonary edema and, importantly, to help reduce that CVP, which, as we discussed, is harming the kidney.
Right, connecting it back. So beyond the heart, we also need to assess the kidney itself directly for signs of that venous back pressure.
Yes. Standard renal ultrasonography is important to assess kidney size, echogenicity, look for hydronephosis, check for signs of chronicity. But the really actionable information, increasingly, comes from Doppler evaluation of the intrarenal venous flow patterns.
Okay, tell me about that.
The kidney turns out to be an excellent gauge of systemic venous congestion. As CVP rises and pressure backs up into the renal vein, the flow pattern within the smaller intrarenal veins changes in a predictable way. It goes from being smooth and continuous
To be more pulsatile.
Exactly. It becomes increasingly pulsatile, reflecting the transmission of the right atrial pressure pulsations back into the kidney's venous system.
Can you elaborate on those patterns? What do they tell us about severity?
Sure. There are generally 3 recognized patterns that are described. The normal pattern is continuous or near continuous venous flow throughout the cardiac cycle. As congestion increases and CVP rises, the flow often becomes biphasic, meaning it's pulsatile with 2 clear forward flow peaks per cycle. This usually indicates mild to moderate venous backup.
Okay.
The most concerning pattern, the one indicating severe congestion, is the monophasic pattern. Here, there's only one significant phase of forward flow, usually during systole, and flow might even briefly reverse during diastole. This highly pulsatile or monophasic pattern often correlates with the severely elevated CVP.
And that signifies?
It signifies significant renal venous congestion, high interstitial pressure, and these patients are at the highest risk for developing or worsening AKI from congestion. This objective Doppler assessment helps us stratify prognosis and really guides the urgency and aggressiveness of our decongestion strategy.
That's very useful clinically. Now, for the most complex refractory cases, sometimes we still might need invasive monitoring, right? the pulmonary artery catheter.
Yes, but it's strictly reserved these days. We really only use pulmonary artery catheterization when there's genuine diagnostic uncertainty. We just can't figure out the volume status or hemodynamics non-invasively, or in cases of truly refractory volume overload or established cardiogenic shock, where our current treatment is clearly failing.
And the goal is?
The goal is to get precise, definitive clarification of cardiac filling pressures, like PCWP and CVP, cardiac output, and systemic vascular resistance. This data can then guide the titration of therapies like inotropes or vasodilators much more accurately than clinical assessment alone in those very sick patients.
This invasive data feeds directly into that concept you mentioned earlier, maintaining adequate perfusion pressure for the kidney. We need to aim for a specific transkidney perfusion pressure target.
Yes, that's a key physiological target to keep in mind. The goal is generally to keep the transkidney perfusion pressure, which you calculate simply as mean arterial pressure, MAP, minus central venous pressure, CVP, above 60 millimeters of mercury.
So MAP minus CVP greater than 60.
Correct. If your MAP is, say, 70, but your CVP is way up at 15.
And your gradient is only 55.
Right, only 55. That pressure gradient is the effective force pushing blood through the kidney's filtering bed, the glomeruli. If the CVP is too high, squeezing from the back end, or the MAP is too low, not enough push from the front end, that gradient collapses. And that can lead to true renal ischemia and AKI, even if the systemic blood pressure number looks borderline acceptable.
It really highlights the double burden, doesn't it? We often need to simultaneously work to elevate the MAP, maybe with pressors if they're in shock, and drastically reduce the CVP with diuretics or other measures. It's a balancing act.
It is. You need enough push from the front, and you need to relieve the obstruction from the back.
Okay. This brings us nicely to a really significant advancement in non-invasive volume assessment that tries to get around the limitations of just looking at the IVC or needing invasive lines, the VEXUS protocol. What is the fundamental utility of this point-of-care ultrasound, VOC-US tool?
Right, the VEXUS protocol, or venous excess ultrasound score. It's key because, as many of us know, relying solely on the inferior vena cava diameter and collapsibility can be notoriously labile and often unreliable, especially in mechanically ventilated patients, but even in spontaneously breathing ones, too.
Yeah, IVC alone can be tricky.
Very tricky. VEXUS offers a more reliable, non-invasive, and objective assessment of systemic venous congestion by actually looking at the hemodynamic effects in downstream organ beds. It's looking for the consequences of that high CVP.
Okay, so how is the score calculated? What are its components? What are we looking at with the ultrasound probe?
So, VEXUS combines the assessment of the inferior vena cava size, usually looking for a diameter greater than 2 centimeters, suggests elevated pressure with Doppler evaluations of 3 specific systemic veins: the hepatic vein, the portal vein, and the interrenal veins that we just discussed.
So IVC plus those 3 veins.
Correct. We look for abnormal pulsatile flow pattern in all 3 of those venous systems. For example, seeing a severe SD reversal pattern in the hepatic vein, coupled with highly pulsatile flow in the portal vein and that monophasic pattern in the renal vein.
That's bad news.
That strongly suggests severe systemic venous congestion that correlates well with a high CVP and, more importantly, with adverse outcomes like AKI. The severity of the abnormality found in these 4 components, IVC size, plus the 3 Doppler patterns, is then graded, giving us a composite VEXUS score, typically graded from 0, no congestion, to grade 3, severe congestion.
And this score directly guides therapy.
Yes, it directly guides the aggressiveness of our targeted decongestion strategies. A high VEXUS score, say grade 2 or 3, tells you objectively that the high CVP you suspect is translating into real detrimental back pressure on the organs, including the kidney, and it demands immediate and aggressive action to decongest. It gives you more confidence to push diuretics or escalate therapy.
So VEXUS is like the bridge, confirming the physiology we're worried about, non-invasively.
Exactly. It helps confirm that the elevated venous pressure isn't just a number, it's having a real pathophysiological effect.
All right, so we've used this multimodal approach. We've confirmed significant congestion, perhaps with VEXUS. This leads us directly into inpatient management strategies. What are the immediate priorities once we've established the diagnosis, say, of type 1 CRS?
Right. The immediate priority is always stabilization. First, correct any life-threatening electrolyte disturbances, severe hypokalemia, or perhaps severe metabolic acidosis, which often accompany aggressive diuresis attempts or can be a consequence of the severe uremia itself.
Good point. Check the potassium.
Always check the potassium. And second, as we mentioned, make sure you've reasonably excluded an intrinsic kidney disease that needs specific treatment. Once those are handled, the mainstay is volume control.
Which means diuretics. Prompt initiation of intravenous loop diuretics is standard. But how do we define the appropriate starting dose? And, more importantly, the titration strategy, especially in a patient likely to be diuretic resistant?
Great question. The initial IV dose of furosemide, or its equivalent like bumetanide or torsemide, must generally be higher than the patient's chronic oral outpatient dose. Doubling it is often a reasonable start.
So if they take 40 oral daily, start with maybe 80 IVs.
At least maybe even 80 to 120 IV as a loading dose. And then critically, you must monitor the response within the first hour or two. Don't wait until the next day.
What are we looking for specifically in that first couple of hours?
We're looking for two things. Adequate urine output, generally aiming for about 100 to 150 milliliters per hour initially, and adequate natriuresis. Check a spot urine sodium concentration. You want to see that urine sodium be greater than 50 to 70 millimoles per liter.
Okay, output and salt excretion.
Yes. If those targets are not met within, say, 2 hours of that first substantial IV dose, that patient is functionally diuretic resistant right then and there. You must rapidly escalate therapy, either by doubling the loop diuretic dose again, switching to a continuous infusion, or moving quickly to add another agent. Waiting just allows congestion to worsen.
Okay, so when we face that inevitable diuretic resistance, the patient's still overloaded. The urine sodium excretion is stubbornly low. Despite high loop doses, we need to employ sequential nephron blockade, or SNB. Can you detail the mechanism again? Why does adding a second diuretic type work so well?
Right. SNB is essential because of diuretic braking and nephron adaptation. Loop diuretics, as you know, work powerfully at the thick ascending loop of Henle, blocking the sodium-potassium 2 chloride transporter. This inhibits a huge amount of sodium reabsorption there.
Okay.
However, this action causes significantly increased delivery of sodium downstream to the distal nephron segments, the distal convoluted tubule, DCT, and the collecting duct. Over time, especially in chronic heart failure, these distal segments actually hypertrophy. They physically get larger and increase their capacity to reabsorb that extra delivered sodium and of water.
Ah, so they compensate for the loop diuretics effect.
Exactly. They effectively start to neutralize the loop diuretics upstream effect. This is a major mechanism of diuretic resistance.
So SNB counters that by blocking sodium reabsorption at those compensatory sites downstream as well.
Precisely. We combine the loop diuretic, which is still essential for its potency, with a thiazide-type diuretic. Metolazone is commonly used because it retains efficacy even at lower GFRs, or sometimes IV chlorothiazide. Thiazides block sodium reabsorption specifically at the distal convoluted tubule.
Hitting two spots.
Hitting two spots. Alternatively, or sometimes even additionally in very resistant cases, we can add a mineralocorticoid receptor antagonist, MRA, like spironolactone or eplerenone. These work further down in the collecting duct, reducing aldosterone-mediated sodium and of water reabsorption. Using these agents concomitantly, the loop plus the thiazide or MRA shuts down multiple sodium reabsorption pathways along the nephron, overcoming that distal compensatory hypertrophy and significantly improving overall natriuresis and fluid removal.
Makes perfect sense. Now, what if even maximal SNB fails? The patient remains refractory, profoundly overloaded, maybe developing dangerous electrolyte issues or acidosis. We have to escalate to invasive therapies, specifically ultrafiltration, UF, and renal replacement therapy, RRT.
Yes, these are truly reserved interventions. The therapies of last resort for volume overload in CRS, or RRT, are indicated for that truly refractory congestion that simply will not budge despite maximum tolerated medical therapy, including SNB. Or they're indicated for life-threatening complications like refractory hyperkalemia or severe metabolic acidosis that cannot be managed pharmaceutically.
The decision to initiate RRT, like hemodialysis or continuous venovenous hemofiltration, CVVH, in a CRS patient feels particularly high stakes. What's the key risk we absolutely must manage carefully, especially concerning the rate of fluid removal?
You're right. It's a high-stakes decision. Patient selection is critical because initiating RRT in the setting of acute CRS unfortunately carries a very high mortality risk and also a significant risk of the patient becoming dependent on dialysis long-term, even if they didn't have end-stage renal disease before.
It's sober.
It is. And if you do opt for fluid removal via UF or RRT, the rate of fluid removal, the ultrafiltration rate, usually set in milliliters per hour, must be managed meticulously. This is crucial. If the fluid removal rate exceeds the patient's plasma refill rate,
What's plasma refill rate?
That's the rate at which fluid can move from the swollen interstitial tissues back into the intravascular space to replace the volume being pulled off by the machine. If you pull fluid out of the blood faster than the tissues can replenish it,
You drop their blood pressure.
you risk causing acute intravascular volume depletion, making them hypotensive, even if they remain edematous interstitially. This, of course, can drop the MAP, further compromise that critical transkidney perfusion pressure we talked about, MAP minus CVP, and actually worsen the acute kidney injury through transient hypoperfusion or ischemia.
So slow and steady wins the race with ultrafiltration here.
Absolutely. We must aim for slow, sustained fluid removal, typically trying to keep the net ultrafiltration rate no more than, say, 500 to maybe 800 milliliters per hour maximum, often even slower, tailored to the patient's hemodynamic tolerance. Gentle, continuous removal is usually better tolerated than aggressive intermittent dialysis pulls.
Okay. Moving beyond the acute decongestion phase, these patients clearly require chronic neurohormonal modulation. They need to be on optimal guideline-directed medical therapy, GDMT, for their underlying heart failure and hopefully to benefit the CRS itself.
Yes, this is where we integrate the foundational medications that target those maladaptive neurohormonal pathways we discussed earlier. We're talking primarily about inhibitors of the renin-angiotensin-aldosterone system, so ACE inhibitors, ARBs, or the combination agent sacubitril/valsartan.
Right, the ARNIs.
And increasingly importantly, the SGLT2 inhibitors. These classes of agents are the absolute cornerstones of modern heart failure treatment and are strongly recommended in CRS because they've demonstrated both cardiac and renal protective benefits in large trials. Beta blockers and MRAs are also key parts of GDMT, of course.
But there's a real practical challenge in the acute hospital setting, isn't there? When do you safely start, or perhaps more commonly, restart these critical agents? Many of them can lower blood pressure or affect kidney function acutely.
That is absolutely where the clinical nuance lies and requires careful judgment. While agents like SGLT2 inhibitors offer profound long-term benefits, their initiation or maintenance during an acute CRS admission requires individualized titration and very careful renal safety monitoring.
So what's the general approach? Hold RAAS inhibitors if they're unstable?
Generally, yes. You should typically hold RAAS inhibitors like ACEs, ARBs, or RNIs in a patient who is actively hypotensive or profoundly oliguric during the peak of type 1 CRS. Wait until their hemodynamic status is stabilized and congestion is significantly relieved before cautiously reintroducing them, often at a lower dose initially.
And SGLT2 inhibitors. They seem to have better renal safety data acutely.
They do. The data, including trials like MPE Kidney, suggest SGLT2 inhibitors can often be safely initiated or continued even in patients with significant CKD and active heart failure, provided they aren't in frank cardiogenic shock or severely volume depleted. In fact, initiating them during the hospitalization, once the patient is stabilizing and improving volume status, might be preferable.
Why inpatient initiation?
Because studies show they can help stabilize renal function and reduce subsequent heart failure events relatively quickly. Waiting until discharge often means missing a critical window of opportunity, and initiation rates after discharge are often poor. So if the patient is stable enough, consider starting the SGLT2 inhibitor before they leave.
Good point. And we should also briefly mention the agents that have perhaps fallen out of favor or have very limited roles for long-term CRS management.
Right. Agents like the vasopressin antagonists, such as tolvaptan, while sometimes useful for managing severe symptomatic hyponatremia in the short term, haven't shown a consistent benefit on long-term heart outcomes like mortality or rehospitalization in broad heart failure populations.
And inotropes.
And inotropes, like milrinone or dobutamine, are strictly reserved for patients in true cardiogenic shock or as a bridge to advanced therapies. They provide temporary hemodynamic support, but have not demonstrated any impact on long-term survival in chronic CRS, and may even increase risk. Their use should generally be limited to specific acute crises and discontinued as soon as possible. They aren't chronic CRS therapies.
Okay, understood. Turning now towards the end of our discussion, we have to address the prognosis. And the difficult truth is, despite our best efforts, the prognosis for patients with significant CRS remains stubbornly guarded, doesn't it?
It really does. It remains a condition associated with very high morbidity. Patients who are admitted with CRS, especially type 1, face high rates of in-hospital mortality, often quoted in the range of 10 to 30%, depending on severity.
That's incredibly high.
It is, and even if they survive the initial hospitalization, they experience recurrent, frequent rehospitalizations for heart failure or renal dysfunction. The two strongest negative prognostic indicators we see consistently are the presence of significant underlying CKD at the time of admission,
That baseline renal function.
and, crucially, the development of a need for RRT for dialysis or ultrafiltration during that acute hospital stay. The initiation of RRT in the setting of CRS often signifies a profound failure to manage congestion medically, and it indicates very severe underlying cardiorenal pathology. Outcomes after initiating RRT acutely are generally poor.
This really underscores the severity and the high-risk profile. It seems to necessitate a fundamental shift in how we often manage these patients siloed between services. It really demands a critical role for multidisciplinary care, doesn't it?
Absolutely. Optimal outcomes, or even improving outcomes from where they are now, require early, transparent, and truly coordinated care. We are definitely past the era where, cardiology primarily treats the heart failure symptoms, and nephrology only gets consulted when the creatinine hits 5 milligrams per deciliter.
Right, the renal consult for dialysis model isn't enough.
Not nearly enough. This collaborative team approach involving cardiology, nephrology, critical care, hospital medicine, sometimes palliative care, must ideally manage these complex patients together throughout the entire hospitalization, especially during those critical phases of escalating therapy or planning transitions of care.
How specifically does that team approach enhance the day-to-day management?
Well, first, the team approach facilitates the effective integrated use of those advanced diagnostics we talked about, like point-of-care ultrasound and the VEXIS protocol. It ensures everyone is on the same page, targeting the same objective measures of congestion and perfusion.
Shared goals.
Shared goals, shared data. Second, it guides optimal pharmacologic titration. Having both cardiology and nephrology input helps ensure the safe reintroduction or initiation of guideline-directed medical therapies like RAAS inhibitors and SGLT2 inhibitors as the patient improves, balancing cardiac benefit with renal risk.
Makes sense.
And third, critically, it supports safer discharge planning. Clear communication between teams regarding the final diuretic regimen, necessary fluid restrictions, close follow-up plans with specialized heart failure and renal clinics. This is essential to prevent rapid readmission, which is so common.
That coordinated discharge is key. Finally, let's look towards the future, because the poor prognosis really motivates a rapid search for novel interventions. We've mentioned the existing pharmacologic tools, especially SGLT2 inhibitors being a major advance. What else is coming down the pipeline or emerging?
Yeah, the pharmacologic space is still actively exploring things like novel anti-inflammatory agents trying to target that cellular damage driven by systemic inflammation we discussed. But perhaps the most promising novel avenues right now involve, I'd say, two main areas: targeted congestion relief devices and specific molecular pathway targets.
Okay, tell us more about these device-based interventions aimed at targeted congestion relief. What are they trying to do?
These devices are generally designed to try and reduce systemic venous congestion before it causes significant end organ damage, particularly to the kidney. Research is ongoing into systems that aim at, for example, splanchnic denervation.
Splanchnic denervation, how does that help?
The idea is to modulate the highly reactive splanchnic circulation, the blood vessels supplying the gut, which holds a vast reservoir of venous volume. By altering nerve signaling, they hope to encourage fluid mobilization out of this reservoir, reducing systemic CVP. There are also other devices being investigated that act as central pressure reducers, perhaps working in the vena cava, focused on lowering CVP more directly.
Interesting. So mechanically offloading the venous system?
Essentially, yes. Trying to do it mechanically or neuromodulationally without putting undue stress directly on the kidneys or requiring systemic drugs with side effects. Still early days for most of these, but promising concepts.
And I also found the research you mentioned on alternative decongestion methods fascinating, specifically the increasing recognition of peritoneal dialysis, PD, as a potentially viable option in certain acute CRS settings.
Yes, this is gaining some traction. For pure ultrafiltration, removing fluid, PD is being looked at more closely for select acute CRS patients, particularly those who might be too hemodynamically unstable for traditional intermittent hemodialysis.
Why PD?
Because PD offers the ability to remove fluid much more slowly and continuously, often over 12 to 24 hours per session, rather than 3-4 hours with hemo. This provides far better hemodynamic stability. For patients who are struggling with low MAPs, maybe needing low-dose pressors, but still desperately need significant fluid removal.
PD might be gentler,
PD can be a safer, less disruptive, and potentially less hypoperfusive alternative to achieve those necessary decongestion goals compared to the rapid fluid shifts of intermittent hemodialysis. It's not for everyone, but it's another tool in the toolbox for specific situations.
Okay. And looking furthest out, you mentioned targeting specific molecular pathways. Can you briefly explain what pathways like Clotho and SOX9 are aiming to address fundamentally?
Right. These are really investigational molecular pathways aiming to tackle the underlying structural problems, particularly fibrosis and mitochondrial dysfunction, that drive the chronic organ deterioration in both type 2 and type 4 CRS. Clotho, for instance, is a fascinating renoprotective and cardioprotective hormone.
Okay.
Reduced Clotho levels are strongly associated with accelerated aging and chronic injury processes in both the heart and the kidney. So therapeutic strategies targeting Clotho aim to potentially restore some of the natural cellular defense mechanisms and slow down that progressive fibrosis.
And SOX9.
Similarly, targets like SOX9 are transcription factors known to be involved in cellular injury repair responses and fibrosis pathways. By modulating these key molecular switches, researchers hope to actively mitigate the adverse tissue remodeling, the scarring, and stiffening that characterizes both chronic heart failure and chronic kidney disease progression. It's targeting the root cause at a cellular level.
Very complex, but potentially disease-modifying down the road.
That's the hope. Still a long way from clinical practice, but represents the direction research is heading.
Okay, this has been an incredibly necessary and, I think, thorough deep dive into a really complex topic. To summarize our key takeaways then, CRS is this severe bidirectional entity where acute or chronic dysfunction in one organ drives failure in the other. And accurate classification using the roncotypes really dictates our initial diagnostic and management path.
Absolutely. And crucially, we established that the primary driver of renal dysfunction, particularly in acute decompensated heart failure type 1 CRS, is now understood to be systemic venous congestion, that pressure backup. This is a major paradigm shift that often overrides the historical focus solely on low cardiac output.
Diagnosis really demands that multimodal approach, combining our routine labs with advanced imaging, including TTE to assess cardiac pressures, renal Doppler to look for venous flow changes, and, increasingly importantly, point-of-care ultrasound using the VEXAS protocol to objectively quantify the severity of congestion and truly guide our therapy intensity.
Exactly. And management hinges on aggressive but monitored decongestion. Using sequential nephron blockade early when loop diuretics alone aren't enough is key. Ultrafiltration and RRT are strictly reserved for refractory cases and life-threatening metabolic abnormalities, always mindful of the risks, especially regarding fluid removal rates.
And we must also carefully integrate the use of chronic neurohormonal modulators, particularly SGLT2 inhibitors, initiating them when feasible during the hospitalization once the patient is hemodynamically stable to improve those long-term outcomes.
Right. However, despite all these advances in classification, diagnostics, multimodal management strategies, we have to acknowledge that the prognosis for CRS, especially once advanced, remains stubbornly poor, with persistently high morbidity and mortality, particularly if the patient requires acute RRT. And this really raises, I think, an important and perhaps provocative question for all of us as hospital physicians dealing with these critically ill patients every day. Given the severe outcomes and that profound long-term risk associated with needing acute RRT initiation in CRS, how can we get better at integrating these emerging device-based therapies aimed at targeted congestion relief or perhaps eventually novel molecular targets into our acute inpatient protocols earlier? Can we do more to actually prevent the need for extracorporeal support altogether? That seems like a critical goal that demands continued research, innovation, and definitely collaborative clinical implementation.